Condor, providing medical and surgical care for animals in Ecuador. And today we have the pleasure of welcoming Dr. Jennifer Johnson.
Thanks, everybody. It's so great to join you here virtually for one of my favorite topics, talking about assessing and identifying pain in our patients. Before we start, I do want to thank Assisi, but also give a little plug to the IVAPM. And if you have an interest in pain management and want to get some more information, go to the website ivapm.org and learn more about our organization. People always ask me, why me? What am I doing? I had my own small animal general practice in the Philadelphia suburbs. I had a special interest in pain management early in my career because I felt like that I was doing better for my patients if I was able to concentrate on their pain. Currently, I'm getting my master's degree at the University of Edinburgh in clinical pain management, which has been really interesting because it's kind of tying together the whole idea of veterinary pain management and human pain management, and that translational research in pain management has been really valuable as well for our profession. So I thought today we'd have a little fun, and I would just give you basic 5 pain management lessons, 5 easy lessons, 5 takeaways from this discussion. The first one is pretty easy. Some of you may think it is easy, that our veterinary patients are in pain. But I think it's a little bit more difficult sometimes because we have a little PR problem in veterinary medicine. We have a little education problem because our clients, one of the first things they say to us is, my dog doesn't do anything that would cause him any pain. What does he do? He's a couch potato. He's just a dog. He does dog things. He's definitely not in pain. He just might be slowing down or getting older. And I think that if you do one thing in your practice every day is maybe start to do a little bit more educating, because clients just don't realize they don't realize that the things that their pets do every day are things that can cause them pain. And this video goes on for a while, but it just illustrates a point as to what our dogs are doing, our patients are doing every day isn't something that people always correlate that can be painful. Certainly, if I did this, I would not be able to get out of bed the next morning, at least for a little while. And the same is true. I don't want to leave cats out of it. Is Fido in pain, but it's Fido and Fluffy. And I hate these videos. These videos I actually pulled off of YouTube, and it's on a site called Crazy Cat Fails. So people post them thinking their cat is funny or failing or stupid, or, and they think it's funny. And I think that this is definitely an educational moment for cat owners, that these cats are in pain. These cats are not funny or failing. We are missing the pain, and we're missing the signs, and we're missing the keys. So yes, step 1 is veterinary patients are in pain. And you may say, okay, well, what's the big deal? We're in pain, humans are in pain, everybody's in pain. Well, the big deal is the second pain management lesson, and that is that by relieving pain, we are going to help our patients heal. And this is a concept that I think a lot of times we forget. I didn't forget it because I felt like that I was not the very best clinician. That whole diagnostic dilemma of trying to figure out what's going on with my patient. If I just concentrated on relieving their pain, I knew they were in pain, relieving their pain, being able to be appropriate that way, I found out that I had better outcomes. And there's a good reason for that. And the good reason is that vicious cycle of the consequence of pain. And we're going to talk about this a little bit more in depth. This is a simple circle. That neurohumoral response to pain is that stress response that increases ACTH and cortisol. In simple fashion, increases ADH, which hits on the renin-aldosterone angiotensin system. That in and of itself will cause a decrease in insulin and testosterone. Decreases in insulin and testosterone creates this feedback mechanism to increase our body's production of these catecholamines, causing increased ACTH and cortisol. So the cycle goes on and on and on and on. So much more in depth is this chart. And I like this chart because it basically says there's all kinds of things going on, not just inflammatory mediators, but changes in the spinal cord and central nervous system, neuroplasticity, that activation of the sympathoadrenal complex causing increased heart rate, hypertension, tachypnea, the endocrine changes, all of these things that are a cascade effect of pain, and specifically uncontrolled pain. But to break it down simply for you, I could say uncontrolled pain compromises the immune system, slows healing, increases complications and death after trauma or surgery, promotes tumor growth, changes musculoskeletal locomotion, neurologic function, respiratory and cardiac function, and sometimes forgetting this part affects mental health, aggression, sleep patterns, anxiety, depression. All of these can be a complication of uncontrolled pain. Important reminder when we're thinking about our patients and the outcomes that we are expecting and not getting because we haven't taken into consideration appropriate and efficient and effective pain control. I kind of call this a DOS study, but I remind you, and there's more than just this study, but this was a really popular one in Cell magazine in 2014. They basically did a real big publicity splash about this. Mice that feel less pain live longer. And what they did in the lab is they took mice and they removed the TRPV1 pain receptor. So that's great because what they found is that the mice that had this pain receptor that was ablated lived longer. The more important factor with this study, and again, we don't feel pain, we get to live longer. But the more important thing is living longer isn't just what we're looking for in ourselves and in our patients. What we're looking for is also better quality of life. So not just the mice, not just that they were living longer, but that we were able to have better outcomes, meaning that they felt better. So they had better coats, they had better weight, they just all along felt better and had better quality of life besides being able to live more years. So if we know that relieving pain helps our patients to heal, why is effective pain management so complicated? And to understand why we have such difficulty with effective pain management, we have to understand the difference as well as the evolution of chronic pain. And sometimes there's a little bit of confusion when we talk about chronic pain and acute pain, or physiologic versus pathologic pain, or some people call it nociceptive versus neuropathic pain. And I again want to make this simple because this is just an hour for us to really just remind ourselves of things that we probably know. And there's a lot of really deep research, but in this hour, I want to just, remind you as your clinicians every day in practice, just to take a little pause and think about it. Why does good pain turn to bad pain? And what the heck is good pain? There is such a thing as good pain. The whole idea of, ouch, I burn myself kind of thing, that physiologic pain, it's a response to mechanical or thermal or chemical nociceptor stimulation, and it follows through the nociceptive pathway, which is transduction, transmission, modulation, and perception in the brain. And it activates this withdrawal reflex. So that's good pain. Ouch, I burn myself, or ooh, that hurts when my hip moves around like that and I'm bouncing up the steps. It's protective. It's It causes this withdrawal reflex. It uses the A delta, the B delta fibers. It says, hey, let me do something. Let me activate the surrounding muscles and be able to prevent further pain because of some kind of mechanical, thermal, or chemical stimulation of the nociceptors. So that's an early warning system. Good pain or acute pain. So what happens when good pain turns to bad pain? And I think of this really simply again, that pathologic pain is still a response to tissue injury or inflammation. It actually follows the same pathway as physiologic pain, but it differs from it because it's either initiated by persistent tissue injury or inflammation, um, and it results in the amplification of the pain response. And I think about this as sensitization and awakening those C fibers. So this is where the C fibers come in. It's not just A delta, A beta fibers. We're dealing with the C fibers waking up and saying, hey, yo, something's happening. And what happens when we get this sensitization? We can't just look at that pathway, back at the pain pathway of transmission, transduction, modulation, and perception, as being two-dimensional, up and down, the pain to the brain and back again. What's happening is there's concurrent ascending and descending influences. It's actually, I love it described as a symphony of neural activity, and it occurs simultaneously in both directions. And what happens is it's a delicate balance, but when it tips in the favor of the excitatory nociceptive messages, that an individual will experience more chronic pain. So I think about that the pain becomes less reflexive, what you see with acute pain, and more of an opinion that the body is forming about its physical integrity. It's almost getting imprinted into our neural system. And thanks to Melzack and understanding the gate control theory, researchers are working to potentiate these descending pathways that inhibit pain. And that's where a lot of the research for effective pain management is headed in right now, because of this interesting changes that we have in this symphony that's going on between the brain and back again. So remember, the take home is chronic pain isn't just an extended duration of that acute pain response. It actually creates physical and pathologic changes on the pain pathway that can be permanent if they are not corrected. So we will see changes everywhere in the pain pathway that creates a problem that may not go away. And how does that develop? It can develop peripherally or centrally, meaning that we have sensitization peripherally, where their injury causes a release of this soup of sensitizing factors, reducing the threshold of nerve firing and increasing the response of nociceptors. And then also centrally with the dorsal horn of the spinal cord and changes in excitability and recruitment of synapses and decreasing inhibition. One example of chemical stimulators which can and will cause chronic pain in is in osteoarthritis. So here we have the damaged cartilage that causes the initial stimulation of nociceptors by the cytokines and prostaglandins. And the signal, while it's transmitted to the dorsal horn. And one of four things can happen when it's transmitted. The pain signal can be sent from there to the cerebral cortex, where the brain recognizes pain, and that's where perception comes in. The pain signal could be inhibited by interneurons in the spinal cord, and the signal doesn't process further to the brain. Or number three could be there's this reflex arc that's back to the muscles and tendons around the joint, which is a reflex reaction, which will cause that acute pull away. In osteoarthritis, it would cause the dog to limp. Or there's number four, which is that neurogenic inflammation, where nerves carry that signal mediated by neuropeptides back to the joint, which causes more release of pro-inflammatory mediators. The key point about this is inflammatory mediators like prostaglandins are both responsible for the joint destruction, that local problem, but the initiation and continuation of the chronic pain cycle. So chronic pain, where the body and the brain break down, there's a lot of things that can influence this. We have the idea that history and has fear and anxiety and stress that we're going to talk about, psychological changes in our patients and in humans and in pets. They've started to study this occur and cause this sensitization. So the three main sensitization changes that we see is that primary hyperalgesia, where your pain response is exaggerated through the roof. And I know we've seen that in animals, especially with chronic back pain. Sometimes you'll see them exaggerate. And if you just do something like pet them normally, they will respond. Secondary hyperalgesia, increase of the area surrounding the initial pain insult. So chronic cruciate disease in a dog now has pain all the way up and down the leg. And allodynia, which is that idea that even touching you in an area that wasn't anywhere near pain or doing something that is non-noxious causes pain due to activation of silent nociceptors. All of these things are chronic pain phenomenon that are much more difficult to treat. And really, a lot of the things pertain to humans, but I want to remind you that we're really all vertebrates share the same basic neural pathway and factors, so we for fish, frog, the lower vertebrates up to the mouse, the elephant, dolphin, dog, cat, human, we we all have that same neural pathway, and there are factors that affect that chronic pain coping: memory, genetics. The changes, the difference is really as we get more evolved inhibitory pathway, as we go up the higher vertebrate scale, that can cause changes in how we respond to chronic pain, as well as social and psychological factors, the biopsychosocial model of pain that may not be well studied in the lower vertebrate species. So here we are with this body self matrix, or the biopsychosocial model. All of these factors having some input into how your patient or how our body will respond to pain over time, and causing changes in the outputs of pain perception and how we act towards pain and how we regulate stress with pain. All of this is related to all these inputs that can be very varied. And I kind of look at these factors in a function of three basic things. One is this first factor that can influence the body, the individual patient's response to pain. And I'm not going to give it away yet. Like, why do you think that I put up the redheaded screaming child and the crazy redheaded husky, and compare it to the laid back surfer dude Spicoli and the golden retriever, who he could probably come into your office with a broken leg and not really show any response compared to this guy over here? Well, the big influence in development chronic pain, and a factor that can influence it, is genetics. So we know from studying, and they just published it in animals too, that there are certain breeds that are more apparent to show higher responses to pain. We know this studying redheads and their response to general anesthesia and analgesics for surgical procedures. And we all have this instinct in general practice, this clinical impression of certain patients that are way over the top in their response to pain. Genetics play a part in the development of chronic pain. A second factor is this, the idea that history plays a part. And this is a pretty messy slide, but here we see the puppy that's getting tail docking. And back in the day when people weren't using any analgesia for this, and a calf getting disbutted as a youngster. And I put in the human because it's important to know that a lot of the studies about historical development chronic pain or learned behavior had to do with studying babies who were getting circumcised. So there's a couple studies here, but the basic point is that a learned behavior can occur if we don't provide adequate analgesia for an acute pain setting. We will have long-term effects. So here are these babies. They divided them into ones that got lidocaine gel for circumcision and ones that didn't. And yes, the ones that did not receive analgesia had a higher pain response to circumcision, but it's important to remember that that just isn't where it ended. These groups of babies, when they were going to the pediatrician for vaccination, they were followed. So response to getting an injection that normally wouldn't be a huge response was much more exaggerated in the set of children that did not receive analgesia for the procedure that happened months before. And the same is true that they've looked at this with cattle with disbudding, and there's been a lot of research with this, that there's an aversion. So calves, remember, there's an aversion to hot iron disbudding. They have a pessimistic bias that postoperative pain results in a negative change in the emotional state in calves, so that they are going to respond to pain sooner. We basically have wind up phenomenon in some of these because of learned behavior. So this is actually a function of neuroplasticity and creates this aversion in the future. And then the third factor is that whole idea of what's happening here. This is one scared cat, you would say, and one anxious dog. And look at this poor horse with the whites of his eyes showing. The idea that stress, fear, anxiety can affect our response to pain. So environmental factors can contribute to the development of chronic pain has been well studied. And there's a difference really between fear and anxiety, remembering that fear is a response that actually can help us not be painful. I love this. A bear is chasing me and I'm running and I stab my leg on a tree branch and I keep running and running and running. And after I get away, I look down and I have this big, huge gaping wound with the tree branch stuck 6 inches in my leg. And I didn't feel that pain because fear blocked it for me temporarily. Anxiety is a little different. Anxiety is the anticipation that something bad is going to happen, and it can actually result in a more intense pain experience. So think about this with your patients that are coming into the practice, that pain can cause fear, anxiety, and stress. Fear, anxiety, and stress can also cause pain. Anxiety levels may be able to predict the pain severity. The take home with this is environmental factors can be key in being able to control pain in our patients. And the idea that we can help reduce pain in our patients by paying attention to fear, anxiety, and stress and doing something about it, being fear-free, giving drugs before office visits, using fear-free handling, prescribing calmer canines to your anxious patients that come into the practice all the time and they're just wound up. We don't want this to happen. We want to do everything we can prevent to have our patients not develop chronic pain phenomenon or pain that is more difficult to control. So that step of relieving pain will help our patients heal. What are the keys to effective pain? How are we going to do this? How are we going to best do this because of all the confusion among relieving pain? How do we get to this point? What are the keys to the no pain? We have acute pain. We're pretty good at that. Everybody understands that. How do we prevent that maladaptive pain? Or if we have maladaptive or chronic pain, how do we get advantageous neuroplasticity? So that symphony that creates a good thing happening to no pain. What are the keys to this? Well, the keys really are to be preemptive and multimodal. And this again should just be a review for you in the back of your mind. Be preemptive. Do not hesitate to provide appropriate pain management in a multimodal fashion by a variety of ways, and be aggressive about it. And that's how you're going to have better outcomes. And Bill Muir knew this long ago, almost 20 years ago, in Veterinary Pain Management, which was published. Wind up or chronic pain or nociceptive pain is so much more difficult to treat. One treatment modality may not control the multiple receptors that are activated in chronic pain. And 20 years ago, we knew there were lots of them. Now we know there are even more. And the bottom line has not changed. That lesson 2, has not changed at all. Be preemptive and be multimodal. So step 3, measuring pain helps us to fix pain. I really like this because I think that this is important. I've had a special interest in using non-pharma options for pain. And when I started to do this, there was a lot of skepticism, not a lot of research as to what we were doing was even working. So you look for options. And Galen said, divine is the work of sedating pain. And I love this. I used to have this poster in my general practice up on the wall to remind my staff that, hey, think about pain, think about pain. And it's attributed to him. And we know a lot about him. He wrote things down and he scrutinizes patients for diagnostic clues. He was really sensitive to just little changes in body temperature and pulse. He examined bodily fluids for sign of any imbalance. He looked at facial expression and skin color. I mean, back in the turn of the century, can you believe that? He interrogated his patients to elicit symptoms that weren't obvious to his own senses or to his own examination. Pain, for example, he talked to them about it. He favored open-ended questions, which is really great, listening to their words rather than using a specialized vocabulary of pain. And he learned so much more. These are all tools that we can take from him and use to be able to create the best pain management protocols for our patients. As veterinarians, we're all stuck on this cycle of diagnosis and treatment. We have a difficult job. Every patient, we do Sherlock Holmes, that idea that we have something wrong. So we take observations and some measurements and some tests and we interpret the data and we categorize the data. We use our brain and say, okay, well, it could be A, B, C, D. Think of all our differentials. And then we come up with our diagnosis and then a plan. And then we develop a therapy that is going to treat whatever disease process we have. But this doesn't stop, because with the therapy, we're doing more observation, measurements, and tests and assessing how we're doing. And in this, we should be assessing how our pain management is helping as well. The problem is that we need to use clues to be able to assess if things are effective or not. So let's go back to the clues. What kind of clues do we use to determine? We do this all the time. Temperature goes up or down. It could mean pain, anxiety, infection, stress, organ disease, organ failure. If the temperature's so low, your patient's ready to die. How about the pulse, that it's fast or slow? Shock, anemia, pain, slow. You have many concerns with a slow pulse as well. Respiration's the same, fast or slow. We are using our senses all the time. We're seeing, we're hearing, we're smelling. We might not be tasting officially. We're touching our patients and we're collecting data. And the important thing to remember is if we don't collect it, we can't improve it. Kelvin told us that collecting data, measuring it, allows us to be able to improve whatever it is we're collecting. So we do temperature, pulse, respiration, and we should add pain to that. And that's the paradigm of taking a pain assessment of our patient every time to be determining if what we're doing, whether it's pharma or non-pharma, is effective. But how do we measure pain? It can be really hard. Qualifying it and quantifying it is incredibly hard. And looking at these images, we clinicians aren't noticing it a lot. Is that bird in pain, or is it just sleeping? What about this outstretched neck in a cow? This horse, he just tired, or is he painful? It's very, very hard. And certainly we've all had patients like the Irish setter who make it quite difficult for us to be able to identify pain, or the cat that is basically just looking exactly the same, whether they're in pain or not. So where do we stand in veterinary medicine? You're all familiar with pain scores in your human doctor's office or hospital or the pediatrician. And what I'm really talking about here is the idea of using something to be able to determine what our patient is trying to tell us. And what we talk about are metrics. And you don't have to answer me now because I can't see you raise your hand, but I just want to know, and I want you to think about that are you employing a standardized pain assessment for every patient all the time? And what most people say is they really are only using it for patients that are in surgery or patients that they think are in pain, which I think eliminates a whole group of possibility. Because if you utilize this, that's like deciding to only take the temperature on 50% of your patients. We want to collect as much data as possible. And there are great options out there. If you're not using one of the easiest places to start is Colorado State. They have chronic and acute pain scales, which are very nice, very easy to use, and very helpful for you to utilize, and you can use them with clients as well. Some practices develop their own numeric scale. We like the 0 to 10 because it was very specific for measuring pain in clinic. Much more popular now is using the Glasgow scores, the Glasgow Composite Pain Scale. There's a short form for canines, which is pretty easy. Hopefully it's something that you could incorporate very easily in all your patients. The feline one is also pretty short and easy. The nice thing is you can put it on clipboards of your patients in the hospital. You can use it on an outpatient basis as well, and you can collect the data. And it's important to collect the data. Here's the cat one and the dog one right on the clipboard and in your treatment sheet. Important to collect the data, because how do you know if what you're doing is working unless you have a starting point and an ending point, a middle point and an ending point? Also, grimace scales have become much more popular. You saw on the feline grimace scale that I just showed that we can use facial expressions. There's one for horses, there's one for cattle, there's one for mice and rabbits. That's really great and very helpful for really being able to validate pain in your patients by looking at facial expression. There's another step too that I think is a really valid and good way to do it, is to get the caregiver, get the pet owner to measure pain in a most objective manner as possible. There's lots of options for canines that are validated. I like the Canine Brief Pain Inventory. Dottie Brown published this back in 2008. You can get it online, look up Canine Brief Pain Inventory, and you want to use it exactly how it is, because it's a nice valid tool. You want to not prompt the owner or with, how do they feel? How's he standing? Just get them to read it and do it. They can do it before they come in with a patient, and then you can have them do it weekly to be able to have response to treatment. So that's awesome. The cat one that I love is from NC State, Duncan LaSalle's laboratory, and there's a great website, painfreecats.org. The reason I love this website is because it's a lot of information about cat pain for pet owners, which I think is ultra important because they're getting used to seeing their dogs limp when they take them out for a hike, but they're not noticing pain in their cats often. And using the feline musculoskeletal pain index is quite helpful to be able to collect data from the pet owner. Really, the result of this is that client education is the key. It's so important. This publication by Sheila Robertson and Duncan in 2010 looked at DJG associated pain in cats, and they came to 3 big conclusions about clients or cat owners. That first of all, animal patient survival depends upon hiding pain, which makes it so difficult for us in office. No matter how much metrics we do, how much clue seeking we do, we still have trouble really identifying pain in our patients by palpation or otherwise, because they're hiding it. The stress of the veterinary visits makes it even worse. So pet owners really need to facilitate the identification of behaviors that may suggest pain. So have them assess pain at home when their animal is laid back, for sure. I often say when I talk and teach about anesthesia, I say this about dexmedetomidine because everybody, this is a little aside, but everybody's always so scared about how low the heart rate goes. And I said, when that dog walks in for a spay procedure, their heart rate probably at home might be 70 or 80 at resting. And when they come in, it's 110, and you think that that's a normal heart rate. So then when it goes down to 60, you're nervous. It's the same thing. If we have pet owners assess at home, we're going to have much better, reliable data as to whether what we're doing is working. So some other options for educating pet owners before we move on to the next key point in pain management. Go to our IVAPM website. There's tons of articles and posters, and download these posters and put them in the exam room or put them on your website or do something to be able to just educate pet owners. Hey, these are some signs and symptoms about animal pain. Okay, so that was number 3, and now we're on number 4. And number 4 talks about other assessment tools, and I like this. We measure pain helps us to fix pain. We know that. Cause, effect, what it was before we did something and what it is after. Many assessment tools work together, and I just want to bring this up to, if you're not doing other assessments to identify pain, there's some cool stuff. First of all, easy stuff, palpation. This dog, little difficult to palpate to determine if this dog is painful. We're doing our exam, we're using our senses, and I just want to give you an anatomy reminder. If a lot of my rehab people, if you do rehabilitation, if you do massage, chiropractic, acupuncture, you're probably very familiar with these muscles. But if you're a general practitioner, sometimes you forget and you're doing things of palpation to determine if your patient is in pain, and you're forgetting these 2 very important muscles, and they're pretty easy to palpate. One is the pectineus. If you reach and palpate that groin muscle, the pectineus in here, that if you have a pain response there, you can be pretty much guaranteed that this pet has hip pain, and you may get a reaction there where you wouldn't have gotten a reaction from typical flexion extension of the hip that you're usually doing. So use your hands and palpate the pectineus. The other big thing is palpating the iliacus, the psoas, that group iliopsoas, very important for lumbar back pain. If you're palpating just dorsally, you may miss it. So again, being able to use your hands in a way to be able to better determine if your patient is in pain. The other thing that's cool is using something like a stance analyzer, looking at weight distribution at a stand with your pets. A little hard to do in cats, but you can do it with dogs. This is a stance analyzer that's commercially available. They have looked at this because most people hear about force plate when they're using force plate or gait analysis in research or in rehabilitation. We can use stance. Mills looked at this in Tennessee a few years ago and said, hey, yeah, that weight bearing evaluation, it compares favorably to the force plate analysis. So it's a nice way to obtain some objective assessment or measurement. Again, a numerical value that you can see if improves or gets worse after a particular treatment that you have determined to use, a pain management modality. Or you could get really fancy and use something like a gait for dogs, so a gait analysis, and be able to collect more tools as to which limb might be the problematic one. Collecting data is really helpful because you're going to be able to evaluate if whatever procedure you're doing or whatever pain management technique you have elected to use is going to be successful or not. Using a goniometer, certainly helpful to collect a goniometer measurement, so the flexion and extension of a joint, or a tape measure to do thigh girth, muscle girth circumference. Helpful because if you're rehabbing or if you're treating the pain of a chronic osteoarthritis and you see improvement in the goniometer measurements, you know that the success of the treatment that you've been employed because you have some objective measurements there. Radiographic evidence, however, doesn't really correspond with the amount of pain. So remember, it's great to take radiographs, but there's no way that you can say that this young patient with subluxated hips and minimal amount of osteoarthritis is less painful than these end-stage elbow or stifle. It tells us what has happened, not necessarily what's happening right now, and really isn't a good objective measurement at all for assessing pain. So the last is monitoring outcomes is good science. So the idea that we can monitor things and be able to see that our patients are responding. How do we know that our treatment is working? Metrics have a lot of shortcomings, and there was a big study about the caregiver placebo effects, and this was really for owners evaluating their dog's lameness. And what they found, 2012, Mike Enzemius was looking at drugs that were used for osteoarthritis, and he found that 44.8% of the time when veterinarians examined dogs for lameness at a walk or a trot, they found that there was a placebo effect when you compared it to that force plate analyzer. So objective tools remained unchanged, but the veterinarian felt like that the animal was doing so much better. And pet owners are horrible too. Almost 40% of the time they felt that their animal had improved, where objective measurements like ground force what had remained unchanged. So that's a shortcoming for us. Measuring is really great, but only if we can really evaluate. Looking at thermal imaging is pretty exciting. I like these images because they're supposedly of a healthy patient going out the door. Hey, I got this new thermal imaging camera. Let me see. Let me take some images of this dog. Well, this dog had an exam and was being recorded as normal. But what we're looking for with thermal imaging is asymmetry. There's an area of increased temperature on the right compared to the left. So very, very, very sensitive, not very specific. It doesn't tell me what's going on. It just tells me where to look further. Here's front limbs, the right front limb and the left front limb of a dog. Hey, one of these sides doesn't look like the other. And maybe we need to look further and see what may be going on, whether it's neurologic or musculoskeletal or inflammatory. So the way thermal imaging works is we can collect objective data, very, very, very sensitive objective data with medical thermal imaging cameras, not the cheapo ones you can get on your cell phone, and be able to look for thermal asymmetry. So decreased temperatures or hypothermia, which is exhibited here, could mean neurologic irritation, vasoconstriction, infarction. Most of the time, this gives us a clue that there may be some neurologic vasoconstriction. Increased temperatures, hyperthermia, inflammation, infection, malignancy, muscle strain. This is what we see typically when we have an inflammatory muscle response. Again, great data to be able to follow a patient. Another great option is to use something that I can't wait till I see it more in clinical practice, a pain trace. So the BioTrace-It technology is coming out where they're actually going to be able to use something this small to be able to measure neurologic, almost like an EEG, impulses in your patient and be able to determine how much pain they're in, what the baseline of pain is, and when there's an improvement. So again, you can use it repeatedly to monitor a patient in pain. So monitoring outcomes is really good science. I especially like to talk about this because a lot of us are using non-pharma things. CBD, herbs, acupuncture, laser therapy, PEMF, this whole idea that we're using things where clients are saying to us, yeah, I think it's working, I'm not really sure. And they have this placebo or this instinct that the drugs that you gave them is working because they know when they take an ibuprofen, they feel better. So they tend to bias their results. So being able to have objective tools to be able to monitor outcomes is completely good science when it comes to pain management. How do we know if what we're doing is creating an improvement unless we collect this data? So I love this. To finish up, I kind of like this study. This is actually using thermography and seeing an area of concern, diagnosing a problem and then treating it and being able to use thermography to objectively measure the improvement in our patient, along with using the feline musculoskeletal pain index at the same time. So here's a cat that was presented just for a senior exam that was not very active, not jumping on the furniture anymore, but just kind of not anything that the owner was completely freaked out about. The physical exam didn't localize any sites of discomfort. What a surprise, because cats never do in the office. They're just sitting there like a bump on a log most of the time, or trying to kill you. But so what do you see? With thermography, we're looking for asymmetry. So this is a lateral right hind limb. So here's the foot, here's the stifle, and here is a lateral left hind. And what I see is a discrete area of hyperthermia here, a more generalized area of hyperthermia radiating from the stifle, particularly over the biceps femoris and sartorius. And, in the left, it's directly over the stifle and kind of decreasing. So these sides don't look like the other. This is something I can show the owner and I can say, even though I didn't palpate anything on physical exam, I didn't get a pain response. You're saying that one clue is that your cat isn't jumping up. She's not jumping up as much as she used to. And now I have a thermal clue that we have an asymmetry here. So I take radiographs. The owner says, yeah, take radiographs. And we find osteoarthritic changes in both stifles. And we recommend that the 16-pound cat lose weight. And because they don't want to do oral medications or can't, and plus we think it's really great to start with the Assisi loop, we do that. So the client says, okay, I'll put this loop on. How do I know it's working? Look how easy that is. It's not not a bad thing to try at home because they don't have to wrestle with the cat. They can just get this done every day. But how do I know that it's working? Because they're like, I'm not sure it's working. I don't know, it doesn't make any sound. It doesn't do any beeping. So we get to compare and evaluate with objective data. So here we have before thermal, before a CC loop, before the PEMF. Here's the right side and here's the left side. You can see the asymmetry. And then we took images 4 hours after. The most interesting thing I see here is not just that we reduced inflammation, we have a more normalized area, and we can actually use the software in the a lot of the thermal imaging cameras to calculate the change in degrees Celsius of the area under scrutiny, the area of interest. But when I look at this qualitatively, I see some interesting things. First of all, we're comparing apples to apples. So we have the same range of temperature right here. So the yellow here is the yellow here. And you have to make sure that you do that. But the other important thing is, what do I see in this cat? I notice now that I didn't notice before that this cat's feet are really hypothermic bilaterally, but there is really significant hypothermia where here it's gone. And that makes sense. 4 hours post Assisi, this tells me that we caused vasodilation, and with nitric oxide release, we have better blood flow. We actually have increased blood flow to the feet, which is a good thing. So you can use things like this as objective tools to evaluate that we are producing some type of change. The nice thing about it is weeks later, you can do it again. And what your goal is when you're doing this data and combining it with a pain scoring, musculoskeletal pain index or otherwise, a pain scoring, is that you can say, okay, you started out with a pain score of 32, now you're at 16. Oh, and the thermal images show that we have a normalization, or your biotrace it shows that we have a normalization of the pain. So using all of these things together can help you better provide quality care for your patients.